All right, so welcome everyone to our webinar on addressing home hazards through health center practice. This presentation and webinar is brought to you by the National Center for Health and Public Housing. And before we continue, I would like to just remind everybody about a few housekeeping items. All participants are muted upon entry. Please make sure that you also engage in the chat if you have any questions or anything that you would like to share with us throughout today's presentation. Please also raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and the recorded link will be sent to you all via email after today's session. I have already uploaded the slides into the chat, so hopefully you're able to download them by now. And also, we'd like to know more about you, so please let us know in the chat your name, your title, the name of the organization that you're joining us from, and where you're also joining us from. And in today's session, I would just like to remind everybody that we may be having a few questions. We are planning to go over a case study. So just please be ready to engage in the webinar in some of these questions. That way we can make this learning experience a very enjoyable one. So the mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. It is my pleasure to be assisting in today's webinar. My name is Fida Pineda Sandoval, and I am the Technical Assistance Manager here at NCHPH. And with us, we also have Olajumoke Oladipo. She is the Health Communications and Health Research Analyst. And we also have with us Dr. Kevin Lombardi. He will be the main speaker for today's webinar. Dr. Kevin Lombardi is a physician epidemiologist and director of research at the National Center for Health and Public Housing, as well as the vice president for research and evaluation at North American Management. He leads national research, evaluation, technical assistance initiatives that strengthen health centers and public housing-based health programs with a focus on translating evidence into practical models that improve care, workforce development, and community health outcomes. His work also includes directing multidisciplinary teams on national assessments and implementation studies, authoring peer-reviewed publications in emergency medicine and public health, and guiding the research and evaluation strategy for the 10-year roadmap for public housing sustainability. Dr. Lombardi also holds an MD from the George Washington University School of Medicine and an MPH from the Milken Institute School of Public Health. So before we also continue, this is just some brief background information about the location of public housing, primary care health centers, and public housing developments. So according to the most recent 2024 UDS data overall, there are more than 1,300 health centers serving more than 32 million patients nationwide. Of these, 485 health centers are located near public housing developments, providing care to about 6.7 million patients. And additionally, there are 107 designated public housing primary care health centers that is specifically focused on meeting the needs of residents in public housing, serving 1.1 million patients. The map to the right basically shows us where these centers and public housing developments overlap and how access to primary care is strategically positioned to support the various of these communities. And without further ado, I will pass it on to Dr. Kevin Lombardi to get us started with the webinar.
Great. Hi, everyone.
One thing before you start, our chat is currently disabled.
Oh, okay. I thought I had enabled it, so my apologies to everyone.
Okay. Well, welcome everyone. First, I'd like to thank everyone here for their service to their communities. For those of you who are at health centers, housing agencies, or in the general ecosystem of serving patients of health centers and residents of public housing, thank you for what you do. What you do strengthens our country and our health system significantly. I'll ask all of you to toss in the chat, who are you? And who do you serve? Answer that for us so we can get a idea of who's here in this conversation. I will be teaching today as a conversation. We are all colleagues. We serve the same patients. And the what we'll be doing is going through information about this topic in a conversational way and in a Socratic way, so that we can all engage with it and engage with each other. As FQHCC employees, as people who serve patients as a living for a living, we are always stronger together. So we hope to bring that to some of that to the conversation today. Oh, we've got some CHWs. Excellent. That is great. CHWs are such a critical aspect of our health system. We'll be talking a lot about that today. Do we have any folks in behavioral health? Any nurses? So the band's all here and great distribution from throughout the country. This is very exciting. So let's get right to it. Next slide, please, ma'am. So just to go over what we're going to go over today, we're going to look at home hazards through a macro and a micro perspective. We're going to look at what health hazards are the most dangerous, which ones impact injury rates, death rates, and so forth. Which are the most dangerous for residents of public housing and other disadvantaged groups. We're going to look at those key demographic groups because there are different ways to serve them. We'll look at rural folks too. Looking at health hazards at public housing or in a rural community are two very different things, and they require different perspectives. We will be looking heavily into CHW interventions and how they can support the primary care realm. And we'll be talking about the screening of this and talking a little bit about value-based care and how investing in these injury prevention efforts is, in addition to being the right choice for your patients, is the right choice for your facility financially in the long run as well, due to the various incentives in value-based healthcare, which we are all affected to by for a certain extent. Next slide, please. Okay. So these slides are created like a consulting document. I would love for everyone to take these on their own, read these papers, and if you feel the need to know things in more detail about these patient populations, the papers are all vetted by me. I've printed them out and drank coffee and enjoyed them quite a bit, and I think you will enjoy them as well. For the purposes of this webinar, I'll be going over the high yield information, but I encourage folks take these and circulate them with your colleagues. And from a wider perspective, is being able to introduce reading of scientific papers into your work group or into your organization is a great way to engage people with things and to build language and capacity as well. So something I always recommend that's a really fun way to meet with colleagues once a month and go over a paper. There we go. You can take turns picking them too. It can be really fun. Um, so Tom et al. Is the paper that I chose to use to describe the epidemiology of this issue is because it uses a very large survey. It focuses on older adults, and they have subsets of data and analyses that look specifically at uh, folks with disability. So these data here are data about the prevalence of common home health hazards. Now, these are folks in the United States over 65 years old, and it was a survey of their homes. So these have been identified and put into the database. So when we look at these data and what they tell us, for those of you who are in the emergency room, this may not be a surprise because these are the injuries you're seeing. But it tells us a lot about the risk environment for the country as a whole. Number one is your trip and fall hazards, 43%. These are the things like cluttered hallways, uh, uh, extension cords, the lamps that have fallen over. These are the things that people fall on, and that in many cases lead to severe morbidity and mortality. Trip and fall hazards for those who have not been exposed to individuals who are older adults and disabled can seem less serious than they are, but they are incredibly serious for people of all ages, but this demographic in particular. The thing that we are there's a number of different clinical things that we are particularly concerned about. We're concerned about head, neck, and back injuries. We're concerned about broken hips. In particular for older adults and for those who are already experiencing disability in a mobility sense. A fall can be life-changing and often is. For older adults, this can lead to a terminal decline in health, a terminal decline in mobility, and with that, a much likelier, excuse me, they are much more likely to experience repeat injuries and they're to experience other healthcare issues as well. It catalyzes decline in older adults. And for that reason, it's something that we are particularly careful about. These data tell us that we are right to be careful because these hazards are incredibly common. If anyone has served in EMS before and been to patients' homes, you can sometimes see this sort of live on TV in front of you. Folks who have experienced falls when you go to their homes, it's also often not a surprise that they have experienced that fall because of that clutter, because of their existing disability. These are things that there are a number of ways we can help to make that better. But in a primary care sense, falls can be very frustrating because when the patient is in the room, you have control over the patient and you can educate the patient, provide them with resources. You don't have the reach into their home. That's why we love community health workers and social workers so much because they're not just able to institute things in the home. They're able to give us information that allows us to understand patient risk and to take the right clinical make the right clinical decisions in the primary care context to lessen their chance of repeat falls or ever having a fall. Poor lighting is right there with the same thing. Poor lighting in hallways, in bathrooms, very common and very likely to lead to injury, morbidity, and mortality. And our cluttered pathways as well. Next slide, please. Now, this set of data specifically looks at older adults with an existing disability. That can be a mobility disability or a intellectual disability. For these individuals, the survey broke the data up and specifically looked at their particular hazards and the most common ones. What this showed us is that unsafe bathroom conditions, incredibly common. Of course, for those of you who work in the ED or in the primary care setting, you will often see patients who have experienced this. Uh, Medication mismanagement, also very common at 31.4%. These are pill bottles that are inappropriately open or strewn about, disorganized systems. Medication mismanagement is incredibly dangerous for individuals, especially for older adults that are often on one, two, three, or more medications for a single condition, type 2 diabetes, hypertension, hyperlipidemia, and so forth. When medication is mismanaged, it leads to inaccurate medication administration. Those pill bottles look like that for a reason. It's easy to understand these things. And that's not something just older adults need. That's something all of us need as people. When those systems are not in place, either because the patient is limited in their ability to maintain them or was just never taught how to do them, it makes it more likely that they will inappropriately medicate themselves. And for patients who take antihypertensives, for example, if they were to skip days and then take extras in certain days because the medication is mismanaged, it's not organized appropriately, well, that's going to lead to volatility in their blood pressure. And if they have volatility in the blood pressure, they're more likely to experience a syncope, and that's a fall. These issues are often downstream, and there's often multiple with the same patient. But being able to quickly identify them and to intervene is important. And for medication mismanagement, these are patients who need to be sat down with a community health worker, a social worker, an individual that can teach them how to organize these things and help them walk through it. Chemical and poisoning hazards are very common as well. Household chemicals in particular for older adults. In particular, when we have individuals that are experiencing dementia or experience a reduced level of consciousness that is temporary, these individuals can often confuse the household cleaners as food items. It's something that happens fairly commonly. And if you look at the labels on chemicals these days, it's very easy to confuse them with food items. In particular, it's not like every toxic chemical has a big orange sign on it. These things often look like food items, and the pine sol can look like olive oil, and or can look like something that you put in your drink, and you may do that and accidentally poison yourself. So these are things that need to be stewarded in patients that have disability, patients that are especially older adults living alone, to know where those are and to have them categorized, making sure they're in safe locations and they are not placed around food or medication, because that just increases the risk of poisoning. And I will say, this is good advice for everyone, not just older adults. Make sure you know where you're putting your hazardous chemicals. Lead or asbestos exposure. Now, for residents of public housing, depending on where you are in the country, I know for a fact, for example, if we have any folks from Boston Housing, they have recently redone in the last 5, 10 years, or in the process, and are still in the process of redoing most of their public housing for in purposes of patient of resident health. And there is, of course, these are new buildings. There's no lead or asbestos in them. But when we expand and look at throughout the country, there are public housing buildings that were made in the 70s. Sometimes the buildings are so old that they need to buy replacement parts for elevators and have them custom made. It really varies throughout the country. So when you're, if you are someone who serves public housing or serves residents at particular buildings, it's good to educate you about the sort of exposures that these buildings have. When were the buildings built? When you're looking at things before 1973, you have a possibility of a lead exposure risk because that was the paint that folks were using. And this stuff, even to this day, when we look at certain parts of the country, there are a large number of homes, including those that are lived in by HUD-assisted residents that still have traces of those paint. When you are lead exposed as a child, it impacts you for your entire life. It impacts your ability to think as a human being as an intellectual and emotional sense. It is truly disabling. It is not limited to that impact is not limited to children. Of course, with any exposure, the earlier in life that you have the exposure, the more likely there will be consequences down the road. But for older adults as well, those consequences are severe, although not quite as severe as when we're talking about a young child. That being said, older adults who are living in HUD-assisted housing in houses built before 1973, and that's a good question to put on a questionnaire, either a non-medical needs questionnaire or a screening questionnaire, is the date that your home was built, because that is an indication that this individual may need a lead test, a serum lead test. Next, and the important thing is here, like, know your community. What's the housing stock look like in your community? If you're living in a different part of the country, a rural area, a urban area, it's going to be different. And these are things you will accumulate knowledge about these things over the years as you serve your patient population. But it's good to get ahead of it. Um, Next slide, please. Now this one's interesting. Here we're looking at risk of various things. Three things. One, falls in the past 12 months. Two, hospitalization rate. And three, functional decline. And what they did is they looked at all of the individuals in the survey, and again, these are people over 65 years old. They counted the number of home hazards in their home, and they averaged it. When they found for the average home hazards, the average adult had 1.9, just about 2 hazards per house. For homes that had over 3 hazards, or 3 or equal to or over 3 hazards, we can see the difference here in red versus the green, which is the average. We can see for those individuals, just an increase of a couple of hazards increases their risk of falling from 27.5% to 41.2%. That's a huge difference. Hospitalization rate up nearly 8%, and functional decline up nearly 40%. That's the impact of just a couple of home hazards added to someone's home. I put this in here just to because I was surprised at how just a little bit could make just such a huge difference. When we look at these percentage differences over a population, these are thousands and thousands and thousands of individuals that experience injury just because they had a couple extra hazards in the home. I think that speaks to the impact we can have when we intervene. And I wanted to take a second to talk about value-based care to a certain extent. And Jamoke, I'll pull you in first. Um, we had a discussion today, and we were talking about some different research we're doing about pediatric asthma, and you brought up something that made me think of value-based care. Can you remind me what that conversation was?
Yes, we were discussing our research with another organization and how repeated hospitalization or emergency department um, visits, how that increases the cost of care to health centers and the hospitals that have to see these repeat patients.
Mm-hmm. Yeah. So what we found in this particular research is that when individuals, this is for asthma attacks, what we found is that we were studying the financial impact of those increased ED visits because kids were having more asthma attacks. And it got us to talking about this issue as well, and about how falls in your patient population, and this is to primary care centers, how it has financial impact on the institution through value-based care. In the traditional fee-for-service model, uh, the health center gets paid for the service provided. In value-based care, there is a cost savings or a cost overrun for patients, with the revenue minus the cost of care being that margin. And in these various models, there are incentives to health center that either give them funding directly, awards, or share that margin. Every health center in America is, to a certain degree, working with value-based systems because they are entrenched in Medicaid and in Medicare. And these systems are part of accountable care organizations as well. So your health center has a variety of different incentives to reduce the cost of care. Those are different for every health incentives. Every health center, they are different for every health center, excuse me. But the incentives are real and they are present for every health center. So when we're looking at falls in particular, it becomes both a patient care issue and a health center finance issue. because when you reduce the patient's risk of falling over 12 months, you reduce their risk of going to the emergency room. Those patients often need to have hip replacements. They're in the hospital for sometimes 24 to 48 hours at least. When you reduce those costs, there are financial benefits to your health center. What those benefits are exactly will depend on the specific financing overlay and reimbursement overlay that your health center experiences, but they are definitely there. And reducing things like falls is a great way to lower your cost of serving each patient and remove risk of some of the most horrifying injuries, especially for older adults. Next slide, please. Yeah, and just to talk about populations with increased exposure to home hazards, these are important pieces of data. Uh, to make one's home disability friendly is costly. Ramps are expensive. Bathroom changes are expensive. These are sometimes covered by health insurance, but not always. And depending on the type of home you live in, part of country you're in, there may be additional hazards as well that are costly. And because of that, as we can postulate, those who are from low income households are much more likely to have a higher exposure to those hazards at home. Those with mobility and sensory disabilities, again, this might seem obvious, but it's worth working through it. For individuals that are using a walker at home, something as small as a difference between where there is tile and where there's carpet is enough to make them fall under the right circumstances. A step is enough, even a small one, just a couple inches, is enough to make them fall. And that's true for individuals with in wheelchairs as well, especially if they need to get up and move around the house for certain things, to get up in their counter, to move around their bathroom without rails. Every one of those movements is a risk of a fall and a risk of a very horrifying injury. And I will say, in particular, in the kitchen and in the bathroom, these are places that tend to have harder surfaces. So if it's in the carpet, at least you do have some cushion there. On bathroom tiles, that's like hitting stone. You're hitting ceramic. That energy goes directly into the hip bone if there is a fall on say your right side or fall in the back of the head. So this is why we often see patients getting concussions. We often see them with hip injuries or hip fractures and back injuries as well. These are severe and life-threatening injuries, and they can lead to death in many cases. A thing to keep in mind for those of you who work in rural areas is, and I did my training in a rural part of Southern Virginia, is the exposure risks multiply, in particular when you have folks that are living on farms or working with animals regularly. I can't tell you how many patients I had that were 80 years old and still had 100 uh, head of cattle that they were taking care of. This was not an uncommon thing where I practiced. And those patients came in with injuries that were related to animals or were related to exposure to chemicals on the farm. Farmers very often work late into their life, and seeing one that's 85 or 90 and still actively taking care of a farm this is a real demographic and one that requires special care because those conversations about aging and about disability accessibility it can be difficult for someone who wants to continue working and is worried about not being able to continue working. My advice for you, know your community and know how to have those conversations with folks based on their cultural values and their understanding. Keep in mind that for folks living in rural areas or living in farms, there are extra exposure risks on those farms depending on what they do and the animals they keep. Next slide, please. Now I'm going to go through some alterations to homes and how we can make these areas a little better and kind of elucidate the costs a little bit too, because these things are expensive and insurance covers part of it at most. For the living room area, if we can remember from our data, poor lighting is one of the most common reasons that folks folks fall. Excuse me, from the perspective of a community health worker who is providing a home visit, lighting should be at the top of your list of what you are looking for. Turn all of the lights on, see how well lit the area is, and keep in mind that as folks get older, as they experience macular degeneration, other eye issues that are common in older folks, their perception of light is changed and they need more than you think they do. So making sure that lights are appropriately placed, that they are bright, and that the important thing is making sure that the individual who lives there knows how to turn them on and can reach the switch and can get there safely. Stair lifts are an inexpensive addition, but they're one that is necessary for folks who have bedrooms upstairs or who need to use the stairs in their home. There is often a difficult conversation that needs to be had with older adults, those with disability, about bringing a bedroom downstairs, changing their living arrangement, or downsizing an apartment. When you're doing a health assessment, uh, look around the patient's house, but also make a point of where the functional areas of the patient's house are and how many times during the day are they going to be walking down up or down these stairs. And of course, ramps. Uh, Ramps and lips. Uh, so oftentimes when ramps are installed, they're installed and there's still a significant lip between surfaces, say the outside of a house and the inside of a house. Those are the things that you need to look for when you're doing these home assessments because it's that little thing, that inch difference, that if you're putting something in or installing might not seem a lot, but that's what makes the walker fall. And it doesn't need to be even an inch. It can be a quarter inch. It can be less. It takes a very little difference in elevation between the end of a ramp threshold and the start of a floor or surface to be enough for a walker to fall. And these are things that we need to pick out when we see them and fix them what we can. And they are all often the cause of injury and high morbidity and mortality, if I will say. Falling when using a walker and hitting your head, it's easy to lead to it's easy to get a concussion that way. Let's just say it's a very common way to get a concussion. Next slide, please. Looking at the bathroom, uh, customizing the shower and bath area is extremely important. There need to be railings put in the bath, put in the area leading to the bath and the toilet so that folks can freely move around without having to walk on tile without support. And again, oftentimes bathrooms have very hard surfaces, tiles, ceramics, and these surfaces, one, are slippery. They have less friction. It's very easy for them to get wet and for them to fall. So having the dual protection of both a railing and pads are incredibly important and greatly reduce the risk of injury. Of course, bathroom is a key part of the home safety check, but I just cannot emphasize enough how important those removing the slick surfaces or replacing them with surfaces that have a frictious surface and having those railings. I cannot emphasize that enough. Next slide, please. The kitchen. Reaching up from cabinets is a great way to fall. Making sure the kitchen has been made for that individual's disability is incredibly important. Are things in the right height for the individual? Are they accessible for them? Can they reach them? And in the kitchen, this is often where folks put their medications, especially if they have a lot of them. Are those clearly different from food? And or other things, and are they organized appropriately? The medication reconciliation and check of where the medications are, check the pill bottles. These are all part of the home safety check, and they are perhaps the most important. Next slide, please. Case study time. Fide and Jamoke, I'll ask you to join me, please, for this. And what we're going to do is do a case study. We're going to talk about a patient. And we are going to, from the macro to micro, pick the home safety issues and talk about intervention, how we would help it. I'm going to read the case study, and the three of us, will have a conversation, and we would like to pull you in as well to have that. This is a creative exercise. It's like, what's the theater where they don't practice beforehand?
Improv?
Yeah, medical. Cool. Mrs. Johnson is a 72-year-old woman with a past medical history significant for hypertension, type 2 diabetes mellitus, past stroke, past MCI, heart attack, and hyperlipidemia. Presents at your health center for a wellness exam post-hospitalization. Since her stroke in 2023, Mrs. Johnson has experienced expressive aphasia and requires a walker for mobility. Okay, so we have a patient with significant chronic medical history, hypertension, type 2 diabetes, past stroke, also a very common patient. You'll see this patient every day, past heart attack, and she was just in the hospital. She's had a stroke, and she has both expressive aphasia, which is when the patient can visualize in their head the word, but they cannot articulate their mouth and tongue to say it. And it often broca's aphasia, very scrambled things come out of their mouth. To them, often it's very fluent, but it comes out expressively incorrect. And a walker for mobility. So she likely has maybe some right-sided weakness, left-sided weakness. It's not clear from here, but after her stroke, she lost both her ability to speak fluently and her ability to walk without a walker. She comes into your health center. It's got all this stuff. Okay, a lot to digest. Next slide, please. We've got a question. So based on the limited information you have about Mrs. Johnson, what concerns do you have regarding her safety and wellness? So again, patient comes in post-hospitalization, has all these problems, has all this past medical history. You're in the primary care setting. What are your safety and wellness concerns for her? Let's get back and let's just give it a minute. And I'll ask folks, please toss something in the chat or raise your hand, the little icon that looks like this. Mine's, it looks like this, like a little yellow hand. I want to see some of those and pull you guys into the convo. What's your concern, Mrs. Johnson? You should be concerned.
Can I say something right now while everybody
Yes,
raises
Fide, are
responses?
you
Yeah.
concerned about Mrs. Johnson, and what are you concerned about?
Yeah, no, the number one thing is her risk of falling. Given all of her, she's a 72-year-old woman, so her age and her medical history, so she's definitely at risk of falling. I would be concerned about like her home environment. What does that look like currently? Yeah, those two things for now.
Yeah. And these risk factors, they are all independent risk factors. So type 2 diabetes, past stroke, expressive aphasia, these all represent unique risks that accumulate and catalyze each other. So I'm seeing some comments here. One moment. Was vision and this is from Lynn Gallison. Lynn, that's a good question. Would you mind sharing it with us? uh, Fide, could you unmute Lynn so we can ask her to please tell us why she care about that and why is she even thinking about vision?
Hi, Lynn. How are you? I have unmuted your line. Hopefully, you're able to participate.
So I'm going to start talking about it and ask you, Lynn, if you can jump in, jump in. So was vision affected by the stroke? We don't know. Does she live now alone? We don't know. And what is her eating ability? We don't know. Can she do her ADLs on the own? We don't know any of this stuff. And these are all high priority questions to ask this patient. If I rephrase the question to say, what are concerns and how do you address those? It's by asking all of those questions. These are things that we should go over in the clinical exam, and these are 100% important things for the safety. So yes, absolutely nailed it. I'm particularly interested about these ADLs too. How before her recent hospital stay, how much was she able to do by herself? Has she experienced a functional decline since then? And here's the important thing, hospital stays go quick. And social workers there, they work quick too. Are there services that she needs that she didn't receive or that the hospital wasn't aware she needed that she has not received? These are questions that when we ask them, we can intervene and possibly prevent a life-changing or life-ending injury. Uh,
Mhm.
So I see some more comments here about assistance in the home. 100%. Tracy, could you introduce yourself and tell us why you care about assistance in the home? Why is that a priority to you? Tracy, I think you're muted. And if you don't mind telling us who you are and who you serve.
Her microphone's not working. Hmm. Okay,
Okay,
no, that's fine. Yeah.
no worries. I'll go through it myself. Why is this an important question, Fide or Jamoke?
Because then that would mean that she would have somebody that could hopefully prevent her from falling. That would lower the risk of her falling and having any further complications.
Yes. Anything
Mhm.
else? There's a lot of reasons why assistance is important and understanding assistance is important.
I think with her aphasia, she wouldn't be able to get help herself. So if there's already someone in the home, they can um, they can look out for her and then get assistance when needed.
100%. And like as soon as I see this patient, I'm thinking, uh, okay, so what happens if she falls? Who does she call?
The
911?
emergency department, yeah.
Can she do that? Can she express herself in that way? Is she fluent enough to be able to do that?
No.
That's a question we need to ask because if we don't and we don't get her a life alert, if she needs it, we could be sending a patient into a dangerous environment without the ability to help themselves. And that's something that can lead to someone being on the ground for 24 hours. Like, are there relatives that live in the area? How often do they see them? This is the social collateral that we collect, and it is vital for assessing risk and vital that the team have this information, that it is in the medical record, it is in the EHR. I love when systems have their CHWs write notes and they are in the EHR because that social collateral will otherwise take you forever to collect in the primary care and in the hospital setting. It's basically impossible to collect. It's incredibly high yield information and incredibly important when you're treating a patient. So for CHWs, when you're doing your notes, keep in mind they are used, and this documentation is incredibly important for assessing risk and to treating patients. And I guess we'll go on because we have a lot of good things here, but I'll say Do we have anyone that wants to join the conversation on this and make a point that needs to be made? Onward.
We
Oh, sorry.
Yeah, and I was just gonna read out loud another good point that was mentioned here about making sure that she has the correct shoes, like diabetes shoes.
Mm-hmm. Mm-hmm.
Um, or from another participant, does she have access to inside house with ramp, and or does she have stairs? What type of tubs or shower? Can we get a health educator? Nutrition reference. Does she have access to foods? And can we get a care provider covered through insurance?
Mm. So the shoes is a really good point. Shoes are a really good point. Uh, Diabetes leads to intense microvascular damage. Sugar is volatile, and insulin insensitivity leads to increases of cortisol and in systemic inflammation. When you have systemic inflammation and you have a lot of glucose in the blood, that is a recipe for microvascular damage. This is why folks can lose limbs in severe cases in type 2 diabetes. And before that, there is a whole story of desensitization. Microvascular change leads to nerve damage, leads to lack of sensation in the feet, and this leads to folks not being aware of where their feet are. Reductions in what we call proprioception, the ability to picture where your foot is or where your arm is in 3D space, that goes down. And thus, the risk of falls go up because of that. You don't know where your feet are, you're going to trip. Um, when you have folks with diabetes, making sure you're having that diabetic foot exam every time they come in is very important. Look at your diabetic patient's foot. Look at them all the time because it tells you a lot about their microvascular health. And next slide, please. Per hospitalization documentation, Mrs. Johnson is noted to experience a fall from standing last week. Hitting her head as she fell, Mrs. Johnson was brought to her local emergency department by ambulance and was admitted to the hospital for observation and blood pressure management for 24 hours. Since her hospitalization, the patient notes no additional falls or injuries. Okay, so what's standing up to us here? Jamoke, Bide. And I'll say everyone at it as well. Unmute yourself. Just jump on in.
Mhm.
What sticks out here?
The blood pressure management wasn't mentioned before, and the fact that she hit her head, so she
Yeah.
might be a little more disoriented.
And this is a question for the group, but it's yours if no one takes it. Is adherence to blood pressure medication connected to falls in any way? What do we think?
Yes.
Yes, 100%. Lynn got it, 100%. 100%. Uh, Tia, do you want to tell us what you think? Are you able to say something? Become one of us. Tell us who you are, who you serve. We're so curious.
Hi, this is Tia. I am lead community health worker for Hamilton Community Health Network. We have 8 total clinics, mostly Genesee County, one in Lapeer and one in Whitmer Lake. Um, so yeah, I'm just wondering, like, right, is the blood pressure high? Is it low? And like, Lynn has stated, it could be due to, her medication. How is her medication management? Is it due to what she's eating? Is she not eating enough? Is like what else is happening here that may have possibly caused the fall? Uh, Higher blood pressure could affect vision, I believe. So those are just
100%.
my thoughts.
Mhm.
Well, one excellent point's incorrect. Two, tell me about your day to day. Are you seeing patients in a clinical setting, a non-clinical setting? Are you communicating with them by phone? Do you engage with blood pressure at all in your work? I'm just curious.
So being lead, I am in administration, but I basically overlook what our clinical CHWs do as well. So we have CHWs at all of our main clinics, our higher, population clinics. Our We have CHWs in office there. And
Mhm.
then also we review anything that's coming directly from the hospital. So like our hospital follow-ups. And we do get alerts, like if someone has uncontrolled blood pressure, those patients we see, and then we can go from there, referring them to a health educator, and then also addressing any barriers that they
I
need. So we
really
look at
like
the
that.
whole patient. I look at the whole patient. We all look at the whole patient, but yeah.
Yeah, that's not only just appropriate but very data driven intervention
Yes.
you guys have
Yeah.
there.
We look
I
at a
like
lot
the
of
use.
data for sure.
I do need to say I like the idea of sending a health educator in. Like, is
Mhm.
this are your CHWs trained to provide this education, or is this a additional part of the member of the team?
It's additional. So we get the training as well. And then if it is, I guess, chronic, and depending on what that HEDIS measure is, then that health educator automatically is pulled in.
Hmm. And are these health educators, are they members of the community? Are they
Um,
local to your area?
yeah. So they work for us. So they are our health educators that are in the clinic. So we have health educators at our main clinics as well as the community health workers.
Yeah, incredible program.
Thank you.
Incredible and responsively crafted. Well done to you and your colleagues. Um, uh, the thing if I were to tell you one thing that you could tell your staff about blood pressure and and how to get them to really understand why medication is connected to this, medication adherence equals stability in blood pressure.
Mm-hmm.
Lack of adherence in any way, and it can be taking two of the pills, skipping a day, doing another one. Oh, I mixed one this day, the next day I'll take two. It leads to volatility. Even for a patient with a high blood pressure, say a systolic of 220, if you have a systolic of 220 and you go down to 160, you're going to pass out
Mm-hmm.
because it's the degree of change. It's not just the number. It's seeing
Mm-hmm.
how much it changes. And sometimes when you're seeing these individuals, they could have a blood pressure of 160, and you'll think, oh, it's not related to the fall. It could be. It very well could be. So just being mindful that is a contextual change. It's not just the number. See past the number sort of thing.
Right. Yep.
Um,
Yes, sir. And then yeah, if a patient doesn't is not like doing, medical adherence, then that provider, say they're in the office, and the provider can send a referral, and that goes, directly to our in-house health educator, and they can come up with like SMART goals and all of that, and then loop us in if they need help with barriers.
Great, great. If I could talk about your program a little bit, again, just from what you're telling me, uh, all of our health centers, everyone is involved in value-based healthcare now. And when you do what you do, you reduce costs for the health center and prevent injuries. So thank you for sharing, and thanks for your service to your community. Well done. So, we're getting close on time here. So no additional falls. We'll go past this. Sorry, Beck. Per hospitalization. Or was this the next one?
Mm.
Okay. So here we go. And this is exactly the situation, right? Initial assessment reveals blood pressure 130 over 76, pulse of 90, respirations 22, shallow. Now, with this 138 over 76, that is based on guidelines, slightly elevated blood pressure. If that patient was previously at 180 or 190, which is surprisingly common with folks who've had blood pressure for years, that's a syncope if you go to that. That makes you pass out. That makes you lose your vision. That makes you hit your head. But this patient is post hospital admission or discharge. And she notes that prior to her fall, she was non-compliant with her hypertensive medication, but received an updated dose and refills at the hospital. So we know the reason of her fall, or we can guess. She wasn't taking her medication per prescription or per orders, and she experienced that volatility, and she had that fall. Now her blood pressure looks better and she got her refills. So at this point, the important thing for the primary care physician is one, changing that if it needs to be changed. If this patient came in like this, I wouldn't change a thing. I'd stick with their regimen as it is, and I'd want to see her within 3 months. For folks who are in the field, this is a patient who needs to have her blood pressure checked. And this is a patient who needs education on medication administration, medication organizing, and so forth. Next slide, please. Here we have a questionnaire. We see that this is a non-medical needs questionnaire. The patient has a need, and this is something, again, there's a link down here. This is the WellRx survey. So it's something that you can take and add to your EHR, be creative with it. It is the links down there. And health centers there is research to support you changing your non-medical needs questionnaire to match the specific questions that you need. So if you live in a rural area, ask more questions about driving. If you live in an area that has a lot of lead and asbestos, ask if their house was made before house was born. House was made before 1973. Anyway, so this patient's having issue with rides. Next slide. Other yeses are unemployed, irregular income, and safety. She mentions that she feels unsafe. Next slide, please. So I'll go through these quickly because we're running up on time. For any questionnaire, if the patient mentions safety, of course, this is a answer that requires a very firm follow-up. Why does that patient feel unsafe? That can be a number of things. In this case, this patient is scared of falling. Fear of falling is paralyzing, and it raises your risk of falling. Just being scared of falling raises your risk of falling. Addressing those risks and making the patient safe, regardless of what it was done. Just the feeling that their house is more safe is going to make them move differently without it, with less trepidation and less risk of falling. So the feeling of safety is important. Think of it as a clinical indicator. Next slide, please. Upon examination, Mrs. Johnson is noted to be alert and oriented. Time 4. Person, place, time, and event. Her physical examination notable for pain upon palpation to her forehead and lower back, with healing bruising noted in each location. So that's from her fall. She hasn't fallen since just discharge. Excellent news. But her gait is noted to be weak, and she requires her walker for movement more than several steps. So the weakness and the needing a walker for movement makes me want to know, as the primary care physician, what is going on at home. What is the home safety situation? I need to know this, and I need these things to address before I can feel safe about this patient. Next slide, please. Mrs. Johnson notes that since her discharge 2 weeks ago, she's been compliant with her medication. Good. And she's seeing a physical therapist 2 times a week. Excellent. She doesn't have any other services. And the next question, we already got Lynn with an answer, is what services does this patient need? And yes, a walker at home may be appropriate. Other services, additional, perhaps home nursing help if needed for medication. A CHW for a home check is a must. This patient is going to need transportation as well. For patients with recent strokes, making sure you are screening for depression is incredibly important. Risk of depression and anxiety after strokes are incredibly high, and we want to make sure that our patients are that the vitals don't just look good, that they feel good too, both in their body and their mind. So please always remember that depression screen and keeping depression at the top of your mind for folks who have recently experienced a stroke. This talks about so patient essentially says that her house is cluttered. Next slide, please. So this was a longer case study than I had thought, so we're not going to make it all the way to the end. But just to do a tour, could you go through the next couple of slides, please, Fide? In this case study, we're looking specifically at the room and we're looking at the areas where there are safety issues. Next slide and the slide after. We can see here it's very obvious. But I encourage you, please take these slides, give them to your staff, and go through the case study. If you're managing and working with CHWs, Tia, you're coming up to mind for me. I would encourage, if it's there, do it, and if it's not, do more of it. Case-based learning with CHWs. That's how we learn things in medical school, and it's an effective way to really understand the conditions. And I think it's a key part of CHW training. So take my slides and use them and enjoy. And for all of you out there at our FQHCs and our housing organizations, it is so important to serve these residents. We save our country millions and millions of dollars in healthcare by serving residents of public housing and folks in HUD and keeping them safe. And we make their lives more stable, more enjoyable, and with better outcomes. So thank you for serving your community, and thank you for joining our podcasts. Excuse me, not a podcast. This is not a podcast. This is a webinar. Thank you for joining the webinar. Thank you for your time. I'll pass it to you.
Thank you. Yeah, thank you so much, Dr. Kevin Lombardi and Jimoke, for your expertise. Also, I would just like to remind everybody very briefly, I know we're like a few minutes over, that we have a few upcoming events. So you will see the links to each of these webinars and upcoming activities in the slides that were just shared with you. So feel free to register. And we look forward to hopefully seeing you all again in one of these sessions. Make sure you also visit us at nchph.org. We have some new resources that we recently published in our website. So please also feel free to have access to that, print them out, share them with your colleagues at your health center. And also complete our post-evaluation survey. Let us know how we did, and we look forward to hopefully keeping in contact with you in the future. And thank you so much for joining us all today. Thank
Sign
you.
up for those sessions coming up. Everything here is physician taught, and it's either myself or my colleague and chief medical officer, Dr. Leone, who will be teaching them. We want to get to know you guys. We want to help you in any way we can. Please reach out and start conversations. We love talking about this stuff, and we are your advocates. So please reach out. And thank you for your service to your community and to our country. Thank you.
Thank you. Bye.